afternoon. Welcome everyone and thanks for being here. I'm Steve Gerber, Chief Development Officer at CICOA Aging and In-Home Solutions. And I'd like to welcome all of you to CICOA's actually our second Envision lecture of 2022. Whether you are new to this lecture series or a new acquaintance of CICOA, or you have been a friend of the organization for decades, it's wonderful to have you join us this afternoon. The Envision lecture series is designed to bring to the forefront issues and trends that impact the health and quality of life of older adults, those of any age with a disability, and their family caregivers. I believe there is an intrinsic dignity in helping people that is very exciting, and I know you do too. We have some 70 people in the room this afternoon, and another 126 plus people have registered to attend online, which is the largest attendance we've had for an Envision lecture series. And that tells me something about you and those online, your commitment to this community. Being able to build support for quality of life for all people along the life spectrum says a lot about the Central Indiana community. Envision presenters are all outstanding leaders in their respective fields. Today we've invited former U.S. Surgeon General Dr. Jerome Adams, who is the Executive Director of Health Equity Initiatives at Purdue University, and Dr. Jasmine Gonzalvo, Professor at Purdue's College of Pharmacy and Director of the Center of Health Equity and Innovation. Their topic is about the importance of health equity, especially for the elderly and people with disabilities. At the end of their presentation, we'll have about 15 minutes for question and answers. So for those in the room, you can submit questions via the cards that are on your seat. Those attending online can submit questions in the group chat. Following today's presentation, we'll be sending out a link to register attendees to access the lecture online, which you are welcome to share with others. But before we hear from Drs. Adams and Gonzalvo, I'd like to invite CICOA President and CEO Tarek Brown to briefly share a few thoughts about CICOA's health equity and initiatives. Please join me in welcoming Tarek Brown to the microphone.
Thanks so much, Steve, and good afternoon, everyone. Someone recently asked me, why should businesses care about community health? I love questions like this because it gives me a chance to explain how the work CICOA does reaches well beyond a client's home. It gives me a chance to tell them that if we want strong, vibrant communities, then businesses, government, and social services all need to be better stewards and stakeholders in promoting community health. For those of you unfamiliar with our agency, let me give you a brief background. CICOA is a nonprofit serving Central Indiana. As the state's largest area agency on aging, we like to say our services start where traditional healthcare services end. Since 1974, we've empowered older adults and people of any age with a disability to live comfortably and safely at home and out of institutional care. We offer a range of supportive services that have a direct impact on public health. These include our Aging and Disability Resource Center, which we like to refer to as the front door to our agency and services, and provides information and referrals to community resources. We offer care management for in-home care, senior meals, transportation, home accessibility repairs and modifications, and support for our family caregivers. In our community, about 90% of older adults surveyed say they plan, as they grow older, to stay in their own homes. but about half of them are unsure if they'll be able to because they don't know if their health will hold up, if their financial resources will hold out, and maybe they don't have family support in the area any longer. Although aging is in our name, CICOA also serves people of all ages, including more than 400 children who have medical disabilities that will impact their ability to live independently throughout their lives. We respect and embrace the differences that make individuals unique. But in recognizing this diversity, we also realize there are systemic inequities and disparities that have created gaps in health and aging outcomes across marginalized groups. Equity in health goes beyond access to medical care. Equity in health starts with a conversation about social determinants of health, meaning how the environments in which people are born, live, learn, work, play, worship, and age affect quality of life outcomes. It takes a look at social and environmental obstacles that may prevent someone from living their best life. According to the American Society on Aging and Justice in Aging's Research Collaborative, race, gender, education, income, personality, and ethnicity all play a role in the experience of aging. Disparities exist around access to resource, disease management, nutrition, mental health care, long-term care, and even end-of-life care. These lifelong inequities contribute to greater inequities in old age. Here's an easy example. People who live in food deserts have difficulty accessing nutritious food, something as simple as fresh fruits and vegetables, which negatively impacts their health. Health equity looks at environments and systems and works toward ensuring that people have fair and just access to achieve their best health outcomes. Other inequities include access to transportation that hinder people from being able to get to work or to the doctor or to the grocery store. When I think of inequities in community health, I also think about safe streets, housing, and sidewalks. Looking at CICOA's program data through a health equity lens, we find that our clients served by CICOA in fiscal year 22 that ended June 30 of this year are primarily white, not Hispanic Latino, and the majority are female. Compared to estimated population statistics for Hoosiers age 60 plus in central Indiana, the CICOA client population has a higher percentage of Black or African American clients at 32.6% versus the overall central Indiana percentage of 12.4%. We also have a higher percentage of female clients, 64.5%, versus the traditional demographic of 55.4% in central Indiana. Ethnicity statistics are incomplete from U.S. Census data. The commonly reported chronic conditions for CICOA participants are type 2 diabetes, dementia, and COPD. Frequency of reported chronic conditions is detailed in the figure on the screen. When prevalence of chronic condition is assessed by race, some conditions show higher prevalence than the CICOA population. White individuals show a higher prevalence of dementia, COPD, and pneumonia than expected based on racial distribution of our CICOA client population, but a lower prevalence to type 1 diabetes. Black or African American individuals show a higher prevalence of type 1 diabetes and heart disease than expected, but a lower prevalence of COPD. Black or African American individuals also show a prevalence of type 2 diabetes that is almost 5 percentage points above expected. Data are collected on types of healthcare utilization, including emergency department visits, hospital admissions, and outpatient visits. Distributions of healthcare utilization by race are similar to that of the overall CICOA client population. Data shows that CICOA clients average 711 emergency department visits, 475 hospital admissions, and 6,322 outpatient visits per 100 clients. When stratified by race, percentages are similar to the overall racial stratification of the CICOA client population, except for hospital admissions, which is 5 percentage points higher. The most common reasons for emergency department visits in FY22 of the chronic conditions mentioned are falls, COVID, and COPD. The most common reasons for hospitalization of the chronic conditions are COVID, heart failure, and pneumonia. CICOA participants were asked if the services they received from their care plan make it easier to manage ongoing health issues. More than half, at 59.67%, strongly agreed or agreed. When respondents who answered does not apply are removed, that number grows to nearly 90%, strongly agreed or agreed. Here's the same data by program rather than issue. Care managers frequently assess healthcare needs, including visits to primary care, unmet medical needs, and if acute healthcare needs are addressed in a timely manner. For the last year, nearly 100% of clients had seen their primary care provider in the last 12 months, did not report any unmet needs, and had acute healthcare needs addressed in a timely manner. One of the ways CICOA's programs help individuals manage their ongoing health concerns is through transportation. More than 12,000 rides were provided in fiscal year 2021 and more than 13,000 in fiscal year 2022 for medical appointments. More than 4,000 rides were provided for grocery shopping in each year, and 148 rides in fiscal year 21 and 93 rides in fiscal year 22 were provided for pharmacy access. The My Freedom program has been used for a variety of reasons, predominantly for accessing medical or dental care. As we seek to improve access for a diverse population in the future, we recognize that every culture, ethnicity, nationality, and every individual has a unique perspective on aging, as well as unique experiences, expectations, and definitions of what quality of life means to them. Responding to the needs of a growing, diverse population of older adults in a culturally competent manner is a priority for CICOA and begins with person-centered and family-centered planning. Although we can never become experts in every culture we serve, recognizing there are differences between cultures can help us lean into differences to build more solid, trusting relationships. Historically, when working with people of diverse cultures with limited English, we have relied on family members for translation or made interpretive services available. But today, we're taking a fresh look at culturally appropriate strategies for outreach and innovation. We've added new mandatory trainings in diversity, equity, and inclusion for all staff. We're changing gender and racial identification options on forms. We're expanding language options for resource and educational materials. We've added accessibility options on our website for the hearing and the visually impaired. We're adding new vegetation and ethnic meals options. We're building relationships with organizations and community stakeholders to enhance diversity of new hires to better represent our community. And we are taking inventory of our business relationships to make sure we are working with vendors that are minority and or female owned. We saw in our CICOA survey earlier this year that access and information about available services is still an item that older adults don't feel that they know much about. This means we must be more intentional about making sure older adults know what we do and that we are here for them. We've started talking to organizations about donating office space to be available 1 day a week for our staff to do on-site, in-person assessments and be a resource in the various communities we serve. A new initiative involves a grant from the Administration for Community Living. Indiana was notified 2 weeks ago that it was one of the 10 states that was awarded a second No Wrong Door grant from the ACL, with a goal of establishing a governance framework for access to services. While we are not sure what this is going to look like just yet, we are grateful and optimistic about what's to come. Most recently, we have added community health workers through a grant from Purdue's Center of Health Equity and Innovation. Our ambition is to have one certified health worker per care management team, so that each team has someone playing this very specific supportive role. I lost my place. These individuals would be focused primarily on assisting with client transitions in and out of the hospital and rehab facilities. Thank you. The initial phase will be identifying our highest risk populations, people that have specific medical conditions that may lead to more ER visits or hospital stays, as we saw in our previous data. Then we will be taking preventative measures to ensure clients have what they need to be successful when they return home. We think it important that community health workers are representative of the communities in which they live and serve to help create a baseline of trust. For example, in communities with high numbers of Burmese immigrants, we want to find and or train community health workers who speaks Chin to help us grow and expand on that trust. While much has been done, we realize that our work really is just beginning to understand how cultural differences shape our relationships with members of different people groups. We want to ensure that CICOA's vision statement of Indiana as a community where older adults and those of any age with a disability flourish truly includes all people. Now, to tell us more about health equity initiatives, please give your kind attention to Dr. Jerome Adams and Dr. Jasmine Gonzalvo. Sorry.
Well, that was incredible. Thank you so much, Tarek, for setting the stage for this discussion because, gosh, CICOA is doing so much in this area of health equity, health disparities. And as the director of the Center for Health Equity and Innovation at Purdue, we've partnered with CICOA for over a year now to really help stand up this CHW initiative. And CICOA has just been so incredible to work with in terms of really doing what's right for the communities and the people with whom they serve. And it's just been great to work with them because working with partners who really are like-minded in terms of addressing health disparities for the communities here in central Indiana and abroad is just amazing. So as again, through the Center for Health Equity and Innovation at Purdue, we do a lot to improve health disparities and improve access to populations who are under-resourced. So CICOA, again, has been an incredible partner in one sector, and we look forward to partnering with them on a lot of different initiatives. So I think I can advance these slides here. And like I said, Tarek did a fantastic job at presenting the data locally, specific to CICOA. And I just want to take a second to provide a little bit of background about myself just to set the stage for where my perspective is, but how much I'd like to hear from all of you as well. So I've been practicing at Eskenazi for over 15 years in a primary care clinic, which serves primarily 85% Spanish-speaking clientele. I see patients who have largely high cardiovascular risk and all of the barriers to care. So that's sort of the lens that I bring to this talk. I also served in a primary care clinic as a clinical role for one of the Eskenazi clinics who served primarily people with serious mental illness. I'm also married to a clinical psychologist, so we have interesting dinner table conversations about how to save the world, essentially. But I also bring that lens in terms of working with a lot of people and individuals experiencing serious mental illness. And through the Eskenazi population, those experiencing homelessness, those who really face the most barriers is really the lens that I bring to this conversation. So looking forward to engaging with all of you in this discussion in terms of what you all are seeing, what you all have experienced, the resources that you access, so that we can have a robust discussion and really provide kind of sort of a comprehensive view and lens and perspective of this important topic. The objectives of our talk today, and welcome to all the virtual people. I want you to feel included. So please, if there's somebody monitoring the chat, I'm happy to be interrupted with anything from the chat as well, or anyone in the room. Please raise your hands as we go. I'm happy to stop and have that discussion as it comes up. I'm a professor, so I'm used to students and anything students bring to the table, which is unpredictable sometimes. So I can handle it if you bring it up during the talk. So some of the things that we're going to talk about today are just identifying some of the health disparities that exist in the populations served by CICOA, which Tarek already sort of brought up, talking about some interventions sort of broadly, what has some evidence base to sort of help and support the populations with which we're talking about today, describing local initiatives, as well as identifying actions that audience members can sort of engage in to support the population as well. So some of that data, Tarek has already reviewed a lot of this data, so I want to mention sort of some of it broadly here. Disability, with respect to disability, I'm sure all of you have seen some of these disabilities at your places of employment or in the communities, with inaccessible physical environments, social assumptions and prejudices, and inflexible policies and procedures that really don't do much to accommodate individuals with disabilities. We can be talking about just the expectation for someone to be able to fill out a form or undress, transfer chairs or tables, and that may be not wheelchair accessible, for example, or even communicate in spoken English. Those are just a handful of the examples that may contribute to some of the disparities for individuals with disabilities. So inaccessible equipment, for example, or inaccessible environments is just one thing in healthcare settings that can lead to fewer preventive tests, misdiagnoses, and delays in care. So that's a broad overview. Does anybody else have anything to add to this? Of what else do you see in your environments, in your places of employment? Jean?
An imposed cost. I had to argue for a client that they wanted her to connect other people, so they wanted the ambulance to take her to the doctor's visit, but that would have been $1,000 out of her pocket. So we were able to negotiate with the office on how she could get care from her wheelchair.
Right. So imposed costs associated with simply accessing care. So yeah, we can do it. It'll just be $3,000 extra. Yeah. Right. Yeah. To accommodate, something that really shouldn't be so expensive. Thank you, Jean, for that. So associated costs, again, just to gain access. Yes.
Barriers to medication management with vision loss or cognition issues.
I'm a pharmacist. You're speaking to my heart here. So medication access was the comment here, and really going through all of the steps. An individual gets a prescription for a medication. There are a lot of barriers that can happen between the prescription, the receipt of the prescription, and getting that medication orally ingested or however it needs to be administered. But I'm sure all of us could spend a lot of time there. I could spend way too much time there. But cost of medications, taking the medications appropriately, the safety that comes along with that, side effects that may result. So medication access, and then safety beyond that. What else? What else do we see in disparities, particular to individuals with disabilities?
Lack of culturally compassionate assessments of the disabilities that aren't visible. So how do we actually assess that in a culturally compassionate way?
Okay, so compassionate care for sort of those invisible disabilities.
What do you mean by that?
Yeah, so,
I think that's important to unpack.
Yeah, it's a lot to unpack, so I just want to throw it out there and keep going. Yeah, I think it's hard to, right now, the assessment tools we currently use in like the healthcare setting or just even in the community setting, they don't really capture that. And I'm not sure people are in environments where they feel they can even say that that is a disability that they have because it isn't visible, or they don't feel empowered to, or just societal norms have not made it easy for them to vocally speak about it. So I think there's just a lot we could be doing.
Associated stigma as well, I'm sure kind of goes in that camp.
And I asked that question because I serve as an advisor to the Special Olympics. And I actually was in New York on Monday and Tuesday as part of a contingent of folks there for the Special Olympics, heading into the WHO, which is there this week and next week. And one of the big challenges when we talk about disabilities is we often talk about physical disabilities, but we don't talk about intellectual disabilities. And for every disparity that you see for the broader disability category, it is that much greater for people with intellectual disabilities because it's invisible in many cases because of the stigma attached to it. And you see variations in different cultures. And that's what was neat about being at the Special Olympics is I got to meet people with intellectual disabilities from Africa and from Saudi Arabia and from Malta and from all over the world. And there are far too many things that overlap in terms of the challenges that they face, but there are definitely cultural differences in the way that they're able to manage and navigate their society based on what is accepted, what is not, what resources are made available in those certain communities versus are not when you look at, again, the European countries versus the US and some of the other under-resourced countries. So I think that's a wonderful perspective, and it was one that I wanted to bring up as a brother of someone who has an intellectual disability, who I've watched really struggle throughout his entire life, and is still struggling, quite frankly. And it would be so much, and I hate to say this, I don't want to say it would be easier for him, but I feel like his life has been made more difficult because it's invisible versus if someone could just see that, hey, you need these resources because you aren't able to walk, because you aren't able to do these things versus you look normal. What's wrong with you? And so I just want to thank you because that's very personal to me that we don't forget about those folks. I want to remind people that 1 in 4, 26% of the United States adults have a diagnosed disability. So we don't, even in this community, we don't realize how common it is. It is more common than any racial minority group. It is one of the most common inequities that we see, or sources of inequity, but people don't realize it's 1 in 4. 1 in 4 people have a disability, and the fact that that number is so shocking to us tells us how many of those are invisible.
Thank you for that, Dr. Adams and Lola, for mentioning that. I think we're really beginning to unpack how complex health inequities really are in these populations, especially when you do introduce different cultures and diversity into an aging and population or population with disabilities. There's a lot to unpack there, especially when we're talking about invisible disabilities, maybe limited health literacy, limited health numeracy. All of those things that, at least from a healthcare provider perspective, is difficult to assess, and we have a lot of work to do. So thank you for those comments. 31% of people with disabilities report fair or poor health compared to 6% of the general population, and among people with disabilities, 55.2% of Hispanic or Latinx individuals and 46.6% of African American individuals report fair or poor health compared to 36.9% of white individuals. African Americans and Hispanic or Latinx individuals over the age of 50 are more likely to have a mobility disability and use hospital services more as compared to white individuals. An Institute of Medicine report said that clear racial differences in medical service utilization rates of people with disabilities that were not explained by socioeconomic variables. And persistent effects of race and ethnicity in medical service utilization could be the result of culture, class, and or discrimination. And so, again, emphasizing those layers of complexity, when we think about something like systemic racism and addressing that from our perspectives as in our respective fields, it's a difficult one to unpack. And I think the work that we've done with CICOA in terms of partnering and highlighting and supporting the work of community health workers who really do come from these communities and identify with some of these lived experience. The CHWs are often those people who have identified, for example, with systemic racism or have navigated similar barriers to accessing healthcare or exorbitant costs. And so CHWs are some of the work that CICOA is doing to address these health disparities directly. When we switch over to unhealthy aging, there are a lot of risk factors for unhealthy aging listed on this slide. For example, tobacco use, alcohol consumption, insufficient physical activity, high blood pressure, obesity, diabetes, again, highlighting some of those common conditions that Tarek was mentioning. But we also have low socioeconomic status, right? So, and that's a big one, right? So all of these are not weighted equally. But when you have a lot of these conditions, if not all of these conditions, compounded on top of low socioeconomic status, that's where we really see significant disparities. Alzheimer's disease is more prevalent among African Americans than among their white counterparts, and there's a greater familial risk of Alzheimer's in African Americans. The genetic and environmental factors may work differently in African Americans, and that plays a role in terms of a higher risk of perhaps dementia in an African American aging population. African American and Black adults experience more rapid physiological complications due to a decline in the body's ability to recover from stress or damage. So this physiological component may actually contribute to some of these disparities as well, among the other layers of complexities that we've already addressed. So economic hardship, shortcomings in primary disease prevention, structural factors, systemic discrimination, obstacles to successful chronic disease management, and effects of discrimination-related stress. The accumulated disadvantage over the life course and inequalities experienced at older ages associated with geographic location of residence, so some of these social determinants of health, gender, and ageist attitudes and practices are all contributing factors to disparities in this population. Dr. Adams, I just want to pause there and see if you have any additional comments on what we really just covered with existing disparities.
Well, you and Tarek both did a great job of covering them. Maybe some additional context. And just so you all know, I was the Surgeon General, and I got to see this at a federal level. And actually, one of my closest colleagues was Lance Robertson, who was the head of the Administration for Community Living during the prior administration. And I actually spoke with him on the way in here today, and he said to tell you all hi. He said to tell you all hello. For me, prior to that, I was the Indiana State Health Commissioner, and I saw this at a state level play out. And so from a professional standpoint, I think something that's very important for us to talk about is the need for better and disaggregated data on people, particularly with disabilities. So again, we often talk about the need to get disaggregated data by race and ethnicity. Incredibly important. But I will tell you that I put out a call to action on hypertension when I was Surgeon General of the United States. I was able to find data on Black versus white versus Hispanic rates of hypertension. I was not able to find good data on hypertension broken down by whether or not you have a disability or not. I put out a Surgeon General's report on smoking. And we know that people who are disabled smoke at 28%, 28% of people who have a disability smoke compared to 13% of the general public. But we weren't able to find further breakdowns on whether or not people who have a identified disability were utilizing different interventions to quit smoking at different rates. We didn't have the data. Diabetes, 16% amongst the community of individuals who identify as disabled versus 7% in other populations. Obesity, 38% versus 26%. We know the big numbers, but we don't know the breakdowns, and we need to call for that data so that we can have better and more informed policies. And this is also personal to me. My mother is both aging and disabled. She has early onset Alzheimer's, and I've watched her struggle. I wish there was a CICOA available to her in her community right now. I'm literally right now struggling trying to figure out how do we help her age in place appropriately, and then how do we help monitor her to figure out, okay, at what point can she no longer age in place with just my aging father there to care for her, and then needs to transition into other living facilities. So I tell you that because if it's this hard for me, I'm a physician. I'm the former United States Surgeon General, and I'm struggling to deal with this. What does this look like for someone who doesn't have the resources, who doesn't have the connections that I have? But to put a different spin on it so we can go forward, I think it's important that when we look at disparities, we understand that there are environmental factors, and Tarek talked about those environmental factors that exist in our communities. There are social factors who you interact with. There are cultural factors, as Lola mentioned. There are behavioral and psychological factors that contribute to disparities. There are biological factors. It's dynamic, it's multidimensional, and we need to really be able to break it down into its individual components, because as Jasmine mentioned, these different components are additive, and beyond even being additive, they are synergistic in a negative way in terms of impacts on certain communities. But to close, we talk a lot about health care. I think it's important that we also talk about employment. Because remember, I said 1 in 4 people in the United States have an identified disability. Significant, and that's down one pathway. We also have this problem where people hit age 65 and our cultural expectation is you're supposed to check out for the rest of your life. But people are living longer and longer. And we're in a country in particular where your worth is determined by your work. And whether we like that or not, that's the United States ethos. So once people the further people get separated from their job, their career, we see the more that we see dementia diagnosed, the more we see depression diagnosed, the more we see people start to struggle. And so I think it's important that we explore those disparities in terms of employment and ask ourselves, how much could it help the individual if we can continue to find ways to keep them engaged in the workforce? And you turn on the news right now, I guarantee you if you turn on the news right now, there's a TV channel complaining about how we can't find enough workers. We can't afford to have 1 in 4 adults with a disability on the sidelines. We can't afford to have everyone over the age of 65 in this society sitting on the sidelines when literally half the businesses in this area are opening up late and shutting down early because they don't have enough workers to be able to open and to close. And so I think employment is one of those places that we forget about because we think of the extremes. We think of the person who's so elderly that they can't really do much for themselves anymore, so disabled that they need significant assistance. We don't think about all the people in the middle who are aging or who have some degree of disability, but who still can very much contribute to society.
Thank you, Dr. Adams. I want to, we kind of started off with a little bleak information, and I want to make sure that we leave this presentation with some hope and with some solutions. And so now that we've covered the facts and sort of the complex worlds that a lot of us are navigating, we're going to get into sort of what can we do about it and what are some actionable items. So going into some proven interventions that have demonstrated improvements in these health disparities. I don't want to be, I'm not going to insult your intelligence and go through a list of things that you all probably do every day. So policy is sort of a broad place where, you know, at any of the institutions that you're working at, are your policies creating disparities? How do your policies address disparities? And is there a deliberate lens of mitigating health disparities in the policies at your institutions? And it's easy to have blind spots when you're talking about policy and saying, oh, well, you know, business as usual, everything's working fine. But when in reality, the policies in place could actually be exacerbating disparities. So I encourage you to, at your places of employment, when you're doing a policy and procedure review, hopefully you're doing that, that you look at it with the specific lens of, are any of these really exacerbating health disparities? Or bring someone in with that level of expertise to say, hey, you're creating disparities by leaving out populations who may be under-resourced. So
that's the real key, is bringing someone in. I talked about involving folks in the workforce, involve them in the advisory situations also. I mean, we wouldn't think that a table full of men could discuss women's health, even though there's some people out there who seem to be trying to do that. But that's not what today is about. That's not what today is about. We can't have a table full of people who have not experienced a disability discussing what the best policies are for individuals who have a disability. We can't have a table of people who are not aging discussing policies for those who are aging. So nothing about us without us needs to apply for reviewing these internal policies and the programs we're putting in place, because there's so much that happens out there, and I see it over and over again, that is well-intended but ill-informed, and so it is less than optimal. And so we don't want that to happen with the policies that we're putting in place, even with our good intentions.
perfect. And you took the words right out of my mouth. I was going to say nothing about us without us. Yeah, yeah. So
I literally took them out of your mouth.
You literally took them out of my mouth. So that, I think, again, not getting into the nitty gritty of here's what you can do, but sort of this idea that look at your policies and do a deliberate review of what is creating health disparities. We know that the health disparities are there, so it's time to look at them and be honest and transparent about them, because our policies are creating these disparities. We didn't get here accidentally. So that's an opportunity that you all have in the audience. I really want to highlight, I don't know these people, but they're in my slides, but they're near and dear to my heart. There's one, hello. They don't know, but they are near and dear to my heart, because this is something that the Purdue Center for Health Equity and Innovation really helped CICOA stand up in terms of saying, hey, CICOA, you know, it would be really cool if you hired a bunch of community health workers. And Dustin and Tarek, that is how that happened. And Tarek and Dustin were like, let's do it. All right. And fast forward, I mean, here they are. So that's really exciting to me, and it's nice to meet you. And here you are, I'm highlighting your work. And I can't wait to fast forward even more to see the impact that these important individuals are going to have on the CICOA community. We really did our due diligence in terms of saying, how can community health workers really help and support the population here at CICOA? How can we continue to sustain and advance and amplify the work of community health workers? And I can't say enough about community health workers, even beyond the CICOA population. They fit and help and support in so many other realms. And for those of you maybe not familiar with the purest definition of a community health worker, it's really someone with lived experience who knows the community because they come from the community. They can connect in a way that I could never connect with some of the communities with whom I serve. I can speak Spanish and I can adjust your medications, but I don't know your experience. And I'm not going to pretend to know your experience, but these people are the ones who have that magical unicorn touch that myself as a healthcare provider never really could. And I'm not even, and that's my privilege, and that's a whole other thing. But community health workers, I just want to lift them up here and say that CICOA has really made a significant investment in community health workers, again, to deliberately address health disparities in the aging population and those with disabilities. So I really want to applaud the work of and investment of CICOA for being a local initiative that's really trying to help.
And that's something I really tried to work on when I was state health commissioner, was lifting up community health workers. It's important to see them as a touch point to the community and helping individuals in the community. But it's also important to understand that when you train a community health worker, you're lifting up an individual within that community. You're giving that community another role model. It is a bi-directional win for the community when you stand up and utilize and support community health workers. And one of the challenges that we have to continue to overcome is sustainable reimbursement for community health workers. So I often say we don't have a healthcare system in the United States. What we have is a sick reimbursement system. We wait till people get sick, and then we do what we get paid to do as a healthcare system. So the problem with community health workers is we're really trying to use them to keep people healthy and keep them out of the hospital, which is where no one gets paid for them at the moment. And we don't have a good reimbursement system, sustainable reimbursement system to pay for community health workers. And so we're always going to be less than optimal in terms of our utilization of these incredibly valuable members of our health system until we can push policymakers to come up with sustainable reimbursement models. And I know FSSA has been looking at how do we fund community health workers, hospital systems. CICOA, kudos to you, but that's not a sustainable overall to try to get individual organizations to pay piecemeal for community health workers. So thank you, because it's important, because what you do is you show that the concept works. Then it's up to us to say, okay, we've seen it work. Now, Mr. Legislator, now, Mr. Regulator, we need you to fund this in a sustainable way.
And thank you, Dr. Adams, for that. And I'm going to give a plug to myself in this moment, because that is exactly what I'm doing. I am working with a bunch of community organizations to say, hey, can I have that data? Because I'm going to take it and I'm going to change policy. So I've been working with a lot of the health systems and CICOA and a lot of other community partners to collect this data to ensure that our community health workers are supported from this sick reimbursement system. It's what we got, and I'm going to change it. So just kind of know that these are the real heroes here, but I'm going to bat for you, and I'll do that from where I stand. But you're doing such important work.
Yeah. Oh no. Well, I mean, I just wanted to maybe relate a little bit more to what do we do? I feel like we have so many good models, so many things that work, but there's this denial in the state of Indiana in so many ways that, you know, how do we really get to policymakers? We can't even expand Medicaid.
So that is a wonderful question, and I'll give you my take, and it's not complete, and it's not the only thing, and some of you may not feel that it's correct, but there was a study they really truly did once upon a time that every time they've repeated it, it's still proven to be true. 80% of people, when surveyed, will tell you that they're an above average driver. Let that sink in for a little bit. Let that sink in for a little bit. So the challenge is that everybody will acknowledge there's a problem, but nobody thinks the problem is with them or in their community. And so to answer your question, that is why I keep coming back over and over and over again to we need the data. We need the data disaggregated. We need the data local so that we can go to each of these legislators and say, no, this isn't a problem in those communities. This is a problem in your community. There's 1 in 4 people in your community who have this issue. There are people in your community who aren't getting the services that they need. And if we do that, then I think we will be more effective in getting some of these legislators on our side who right now can easily say, that's not my issue, even though we know that it is, but we don't have the data to show them that it is their issue. And I think, Tarek, it's funny because I don't know if you were using some of the words from my report or not, but I put out a report. I put out a report as Surgeon General called Community Health and Economic Prosperity, where I talked about the link between health equity and healthy communities and our business bottom line. And so what happens if someone, well, look at my own mother. How much of my time during the day is occupied fielding phone calls on behalf of my mother, or fielding who's aging, fielding phone calls on behalf of my brother who has an intellectual disability? When we don't meet those community needs, not only do we lose those individuals, and my brother actually has been in and out of jobs. He hasn't had the support he needs to be able to maintain those jobs, but he can be a functional part of the workforce. I'm not as productive in the workforce, but if we provided those community supports, you get 2 more people fully engaged in the workforce. It is part of our business bottom line. It's the individual, but it's also their periphery that's affected if we don't provide these supports for individuals, and we need to make that business case. Also important to know that half of the covered lives for the number 2 expense for most businesses is healthcare. The number 2 expense. General Motors pays more for healthcare than what they do for the metal that goes into your car when they produce a new car. And half of those of that money isn't going for the employees, it's going for the employees' families. And so if we can actually prevent disease, prevent disability, we lower their health care cost, which makes them able to produce a car cheaper and compete better against all these other companies out there, the Hyundais and the Hondas and the Toyotas of the world. And they're more competitive. Why? Because they invested in a healthier community, which is better for everybody. And so when we make that business case for health equity, then you also have those folks calling up your legislator and saying, this isn't just about helping poor people or helping black people or helping folks who you don't see in your day-to-day existence. This is about helping your bottom line. And when Dave Ricks speaks, people don't listen because he's involved in the healthcare industry. When Dave Ricks speaks, people listen because he's one of the largest employers in the state of Indiana. They listen because he's a businessman, not because he's a health advocate. But they listen. And Dr. Kane will tell you. Dr. Kane and I will go to meetings and she'll say something, and then I'll say something, and then Dave Ricks will say something. And then what makes the news? It makes the news when Dave Ricks says it. And so we need to understand that if we make that business... She is on her way. But when you're a billionaire, you can't just hold on to it. You got to have a whole bunch of employees. You got to start up a company. But like I said, when we make that business case and when we show people the data to show how it impacts them and their business bottom line, then we have success. And I've actually seen that happen. So it's not just talk. When I was state health commissioner, I had to do that. I had to do that to make the case for funding that I wanted for syringe service programs, for infant mortality, for a number of different interventions that if framed in a way that didn't resonate with those policymakers, would have been pushed off. And it's important that we make that moral case, because we want people to hear those stories. We want them to understand the moral impact of what they're doing, but we also have to show them that it's going to impact their daily lives and their bottom line if we want to be successful. That's my opinion.
Am I allowed to make a comment?
Yes.
Of course you are. You know, he highlights a really important point, but I do want to say this, and Greg Porter, would you not go, because I'll go comment about you just in a minute. I want to say that, you know, at the time, the environment was not great for talking about safe syringes, where you're offering free needles out there for people who were addicted. Because we had the largest hepatitis C outbreak in the state of Indiana. We had over 1,000 new cases in 1 year. And so when he was health commissioner, he was a strong proponent of pushing that. But what I also have to tell you is, you know, our state legislator over there, Greg Porter, you sometimes have to be able to talk with them and learn from their expertise about what can motivate our policymakers, okay? We can't always make the assumption they're going to be negative and they're not going to do what they have to do. We made history at the Centers for Disease Control and Prevention because our city council, which had over 25 members, and about the majority, I think 16 or 18 were Democrats, but there were about 14 that were Republicans, unanimously passed a safe syringe program, every single one, bipartisan, not a single no. So we are capable, we should never give up the fight of educating, advocating for our health equity, but we have to have those critical partners who have that expertise to help us sometimes navigate those waters that can be kind of difficult, but we gotta highlight and let the whole community be aware and get that groundswell support about things that are important for our community.
And Representative Porter, I see you getting ready to run out, but no. This question was actually related to what you do each and every day. And Representative Porter has been a tireless advocate. And what are your thoughts? How do you, because you have had success. Sometimes you're the angry man, and sometimes you got to be the angry one. I understand, but you've had a lot of success actually reaching out to your colleagues on the other side of the aisle. How's that happened?
Thank you. Thank you all. I think one thing that's truly is current is about data. And when you talk to my colleagues across the aisle, it's data driven. What does the data say? What are the results? And with individuals like you on the front line, it's very important to get that information to us. You won't have a problem with me, but what our goal is to try to turn individuals' minds. And it was something that was pointed and said earlier, is that it doesn't happen to my community. We will, and I speak in general as the legislature, not some individuals, but in general, we'll continue to put our hands in the sand and say, that doesn't apply to me. It's also about terminology. When you call it needle exchange, it was, oh no. But when you change the terminology, it says syringe exchange. You're like, oh, okay.
Syringe.
Say syringe. Oh, okay. So it's also about the data, but it's also about the language that somebody can touch and understand. And so, even when we go into this upcoming session, the budget session, we have about $6.2, $6.3 billion surplus, and we still have money from the Tobacco Master Settlement Agreement. We will continue to try and look at those as leaders, to bring that information to us, what I saw today, and then take that information and say, this is the reason why. If we want to keep people out of long-term care or whatever, what is the workforce saying? And so that's very important. What are the dollars? How much they want? We always talk about our return on investment, okay? And we have to also turn it as a business. This is a business, not a social program. And it's economic development, which is employment, and the whole systemic changes that we want to make throughout our state.
And I'll just finish with one more point. When you look at the opioid epidemic, that has been the place where we have had the most bipartisan cooperation. And why is it? Because we finally got to the point where there wasn't anyone in the legislature who didn't have someone in their family who was touched by it. So it's not my community. It's, oh, my neighbor's son had an overdose last week, or my cousin or my nephew had it happen to them last week. I tell you that because when you talk about taking care of people who are aging and taking care of people with disabilities, 1 in 4 with disabilities, everybody's got a grandmama or a mama out there who's aging. This is something that is ripe for bipartisan support and cooperation, but we need to show people the data and show them how we're going to help their mama, their brother, their neighbor in their community. And if we do that, then I think it's a situation that's actually really ripe for bipartisan support from a legislative level, particularly as compared to many of the other things that we've had to fight for out there, where it's a lot harder to show them that it's impacting them in their community. So thank you for that question. And sorry for derailing.
That was amazing. That was, I mean, we couldn't have scripted that. That was amazing. That was fantastic. And 2 things I want to comment on off the coattails of that. Back to your question, I can't emphasize enough grassroots advocacy as well. It moves people. So your voice matters. Everybody in here, if you care, send the letter, make the call. It doesn't fall on deaf ears. Yeah. One call actually does make a difference. If that legislative assistant to that legislator hears 5 is kind of like, whoa, people are paying attention to this. 10, 20, 30. Grassroots advocacy, absolutely. So if all of us are sitting here in this room and care about disparities and for this population and others, we can do something. So that, and secondly, I want to give a good example of data here, and I want to also lift up my friends at Vanderburgh County Health Department too. Their CHW program since 2018 has had 0 maternal deaths and 1 infant death since 2018. And that is a CHW-driven program. And that's some of this data that everybody's saying. I'm like, who needs to see this data? This is amazing, right? And they have the reimbursement numbers. They've been reimbursing. So again, I'm doing the data thing. I'm going to do the grassroots advocacy thing. I'm going to find the right players at the table. I hope Representative Porter comes back and I can maybe get his ear too. But that's how we're going to change policy. But I think everybody in the room too has a responsibility to contribute your voice as well.
And we're from Purdue, Jasmine and Lola and I, but you've got Ball State, you've got Butler, you've got DePaul, you've got Vincennes, you've got IUPUI, at least for a little bit longer. You have all these academic institutions around, and we aren't leveraging the faculty, the staff, the students at these academic institutions to help us crunch this data, to help us run these numbers. We have literally an army of people out there who are making up projects out of thin air so that they can actually complete their degree programs. When if we actually could partner with them, which is what Jasmine has been doing with Vanderburgh County, we can help them publish their data and then have that information to put in front of Representative Porter and say, see, this isn't just a feel-good program. We actually saved you money. We actually bent the curve on infant mortality. But one more quick thing that I don't want to miss that I think is important when you ask the question, what proven interventions have demonstrated improvements? I'm the chair of a company called Total Diversity, and the chair of the board for a company. And the mission of that company is to increase diversity in research. And again, when we talk about diversity, people think about racial and ethnic diversity. But one of the things we need to do is increase the number of people with a disability involved in research, because those folks do tend to have different outcomes at times we wouldn't expect, to different treatments, different programs, different remedies, and they are woefully under-included in research. So I think that's incredibly important. And then as healthcare providers, we'd be remiss if we didn't talk about the need to better train healthcare providers to serve those who are aging or disabled, because I can't tell you how many times I've seen in my hospital, and I work at Eskenazi, and they do a better job than anybody around at taking care of people who are under-resourced and underserved. But how many times even there, I've seen people come in with a disability, visible or invisible, who are not treated at the same standard that someone else would be when they come in, simply because the providers haven't been trained in how to do it. The resources aren't easily available. There's bias that's baked in that we don't even recognize when someone comes in with a disability. So we need to better train our health providers, and we need people who are aging and disabled more involved in research. And those, when we do that, those interventions have been proven to decrease health disparities.
Thank you for that. And it was interesting, Dustin and Jean and I were having a conversation about how we're going to start doing just that, training our students to be more attentive to these communities with individuals with disabilities and all those aging as well. Second, yes, please, Lola. Yes.
Because this has been something that's kind of been rubbing me for a while, but I'm finally getting my aha moment. So we've talked a lot about people who need to be able to be in a position to get in front of politicians and kind of rub their egos. But I think it's important for us to know, like, that's why it's important to have diversified teams. I will tell you right now, when Jerome Adams joined our department, my first question to him is, what are you doing here? I wanted his truth, and I said, I want the real answer, not the one you give. And so, like, I want to know, what are you doing here? And his answer was to the effect of knowing what his role was. His role is to come do the work of getting these health equity initiatives moving, knowing that sometimes that work takes you spinning stories in a way that would mean something to those individuals. That is not my, and he told me, that does not need to be your role. I want you to work in a way that works best for you. And I think that's important because some of us may be sitting here like, I don't do that. Like, I'm going to come up and say black and brown people are dying, period. And people will probably look at me like, that's what I'm here for. Like, that's what I do. And I think it's important for us to really uplift each member's role in a team and let them be most fulfilled in the way they do things. So I think that's important when we talk about health equity, that we're thinking about our teams and diversifying and not forcing people to go outside of the roles they flourish.
Thank you for that, because I think people on both sides, I talk about there's a difference between activism and advocacy. And they cross over at times. You can be both an activist and an advocate, but you need to know which hat you're wearing and in which environment. And if you don't want to be both, it's fine to be an advocate, it's fine to be 100% of an activist. But again, you need to know which audience you're talking to and which hat you're wearing. And you need to have a friend who you can phone when you need someone to do something that you aren't comfortable doing or don't have the skill sets to do. And so we do need to lift up everyone. And one of the things that I've tried to be better about, and I'm so glad you mentioned that, is never to discourage people if their comfort zone is to be, on fire, because they're out there, they're the ones who are creating the space for me to come in and advocate. They're the ones who are drumming up the attention to the issue that then Greg Porter's friends say, oh, we got to shut these people up. Something's going on. Dr. Adams, come on in and tell us how we fix this. They're creating the space. And so it is it's everyone working together. And so I want you to know that I want to be that person who blocks for you so that you can run the football into the end zone and spike it. And I'm perfectly happy doing that. But again, you need both. Thank you, Lola.
Thank you, Lola.
And she did. She gave me the business the first time I met.
Lola will give everybody the business unapologetically, and that's why I love her. So I think one, sort of community or group of people who we would be remiss not talking about in this conversation is unpaid caregivers, because the communities with disabilities and those aging are being taken care of by unpaid caregivers. And even Dr. Adams, I think he's well paid, but him taking care of his mom and taking care of his dad is off the clock. And so these people who are the unpaid caregivers of these communities are suffering and at risk for mental health problems or issues. And all of you are familiar with that, and the economic impact of unpaid caregivers and their mental health is also incredibly important. 1 year value of this unpaid caregiver activity was estimated as $450 billion in 2009. That was a long time ago. I don't even know what it is now. So that's incredible. So it's another population and community of people who we really need to be paying attention to, the unpaid caregivers who are working alongside a lot of the CICOA employees, but also paying attention to the disparities in care that are actually going to result for the unpaid caregivers because they are caregiving. And so again, if those unpaid caregivers are also from those communities and groups that are suffering from those disparities, I mean, again, the problem is compounded again. So this is definitely a group that we can't lose sight of as well. So caregivers can be at an increased risk of negative health consequences. Over half of caregivers indicate that a decline in their health compromises their ability to provide care. They are 12 times more likely to experience the most extreme of adverse mental health symptoms, including serious suicidal thoughts. So in this conversation, again, does anybody have anything to add? Yes.
Just working with my clients, those that are caregivers for their family members or those that are just working in the field. I know a lot of them, especially my family members that work, I feel like they need just some training, you know, because you wouldn't think that somebody would need to be trained on how to take care of their mother and father, but you really do.
Yes.
Because just as a nurturing way, you really want to, I got to do everything for them, you know, and some of the clients I have don't want them to do everything because they still want to feel somewhat independent, but then some of them like, yeah, do everything, you know, and it takes that independence away from them when they really need it. And like you said, it really, you know, drains on the caregiver's health, you know, because they're trying to do all these things, not to mention if they happen to be working. You know, so now they're working 24 hours a day, basically 7 days a week, because they might be working a part-time job or something, but at the same time, I want to take care of my mom, I want to take care of this person. And then on the other side, you know, those that are, you know, working for companies that are attended care providers, you know, just to me, just really having that better, more productive quality training. Because I used to be a direct support, you know, a long time ago when I was like in college, you know, and I'm like, you know, I'm like 20, 21 years old, taking care of elderly people, which I did well, but I've seen some others in my age range that did not do so well, you know, even though we received the same training. I think the quality of training could have been better to say, hey, these are the type of conversations you can have with them, because I have a lot, that's like a big, huge thing with a lot of my clients now. They're older, they're like, I don't know, just have your personal one. You know, just that, how do you communicate with these, you know, individuals? How do I help them be independent if they're a more independent client? You know, and just really helping them with that quality of care of, okay, this is how you properly live or properly do things. I think actually having somebody that might help shadow them instead of just the book training.
I think that that's a really important point, and I'm glad that you bring that up. And we were having a discussion up here about how CICOA has the opportunity to provide those different levels of education, not only to the communities with whom they serve, but also unpaid caregivers or employees, healthcare professionals, and CICOA really sort of looking at that role as another opportunity. So I appreciate that comment.
Actually, CICOA has produced a video for caregivers to talk about what training is available, and even the mechanism of how, if you're unpaid, there may be some methods for certain caregivers in order to get compensated, but even what those are you about to talk about?
No, I'm not interrupting you. It was almost like we segued very nicely with what you were saying. So please continue.
But they have a different training team.
Yes.
I know because we got me involved in the training team. But it also talks about for those who are just getting into the business of taking care of a parent my sister was one that took care of my father, and her health really deteriorated significantly. But as a sibling, I never realized it, and she never said anything until significant damage was done, and that never should have happened. We addressed it immediately, but one, you have to have those tips how to take care of yourself. Some people are taking so much of their care from their sibling, they never have time to go to get grocery shop, they get their hair fixed, or just even have, yes, just even time for themselves. And so CICOA can be a great resource to say how you might get support for that. But also, and you weren't even aware that that support was out there that you could get in order to take care of your loved one.
Thank you, Dr. Kane, on that.
I had a question over.
In addition, yeah, and I'll make this one comment just to, in addition to all of this, the resources that CICOA has, that's what's on this slide, just some additional resources for caregivers. Yes, please.
But I think sometimes when we're talking about caregiving in a one-directional fashion, but a lot of times caregiving is bimodal. You have a lot of people who take care of adult children who move back into the home, and also taking care of either disabled or elderly patients, loved ones. And we're forgetting that caregiving also can be seen as a medical diagnosis. There actually is an ICD-10 code for caregiver burden. And as providers, we have to do a better job of recognizing caregivers who are struggling and give them the diagnosis that also helps them to get some of these resources to help them with caregiving. And that's something we can do as well.
And that's that provider training. Thank you for saying that. Yeah.
I'm a social worker at Senior Living Center, and I know that one of the resources for caregivers would be the Medicaid waiver. However, the red tape and the application process to get that through, where a parent or a family member would not be a caregiver and an actual trained professional would be a caregiver, it's just a challenge, and it has been my challenge. And on a daily basis, I am trying to encourage and uplift and empower the family caregivers as we're still working through those application processes to get that waiver. And I'm just unsure as to why the application process has to be so, why does it have to be so intense when it's obvious that those needs are there?
So I agree, and I wish there was a solution to that. And I think that goes back to some of what I was talking about in terms of policies and procedures that are in place that just make things difficult and create disparities. I think that's a perfect example, right? And there's obviously a ton of opportunity there to revamp that process, but that's a really heavy lift.
And a couple of quick points that I would add on. Number one, I think it's important that we continue to explore and expand respite care programs. Because at the end of the day, professionals who are caregivers aren't doing it 24 hours a day. But unpaid caregivers in the home are doing it 24 hours a day, and it is not sustainable. And if we want to enable people to be able to age and live in place, then we need respite care programs so that those individuals get a break, both for the benefit of the person being cared for and the person giving the caring. That's number one. Number two, I want to give you another reason why the comment about training is incredibly important. Because Representative Porter talked about return on investment. And we had this same problem with community health workers, where everyone said, it's a good idea, but how do we know what we're getting, what we're paying for? How do we know these people are actually providing a valuable service? And you need to collect the data, but part of it, what we had to do with community health workers too, was to say, look, we're gonna have training. We're gonna have certifications for people so that we know that they are actually providing a service at a certain standard or level. So providing that training helps put them in a better place to do it appropriately, but it also helps put us as advocates in a better place to go out and say, and that's why you need to pay these individuals to provide at-home care, because they actually have taken taken training, they're certified, they're providing a quality that we know is going to be likely to keep these individuals out of the hospital, where it's going to cost us more money to care for them, or out of a nursing home where it's going to cost the state more money to care for them, or avoiding an ambulance ride where it's going to cost the state more money, the state and the county more money to care for them. So that's where that training comes in. The VA is actually looking at this, and when I was Surgeon General, we had a whole task force with the VA and ACL looking at this, because in the VA system, if you're a veteran, there are pathways where it's like Medicare, where they have to pay. And so they essentially are like, look, if we can't help people age at home, we're going to bankrupt the VA when you look at the silver tsunami that's coming. And so they're aggressively exploring ways to pay caregivers at home to be able to care for individuals, because it's cheaper to do that than what it is, again, to find them a bed in a VA facility to be cared for. So stay tuned, pay attention to what they're doing. And again, we need to support the VA in their efforts, collect the data, and then say, look, it's working for the VA. So we need to do this too, Indiana Medicaid. We need to do this too, Medicare. We need to do this for our patients out there and our caregivers, most importantly.
I want to be mindful of our time. These are just screenshots of just some of those resources that I put. I'm preaching to the choir here. More caregivers are needed and will be needed as the aging population expands. So what can anyone listening in the audience today do to support equity for individuals with disabilities and in the aging community? And this is where I wanted to have a discussion and open up the floor for discussion, because if we all had the answers, then maybe we wouldn't even be sitting here. So what would you say that audience members can do today?
I'll start off with a big one while you all are getting teed up. But I think one of the things we need to do is operate from a strengths instead of a deficits perspective. And the gentleman over there talked about the bimodal nature of caregiving. There is a value in having Big Mama at home with the grandkids and the great-grandkids, sharing her wisdom and teaching them how to be productive, particularly if you are in a household where mother and father are working 2 and 3 jobs and can't always be at home. So there is a strength there and not just a deficit in terms of keeping grandma or grandpa at home. There are, again, the ability for those individuals to participate in the workforce in some way, shape, or form. One of the things that I've always pushed for, we know that the biggest predictor of whether or not a young person is going to go down a negative pathway, particularly if they have an accumulation of adverse childhood experiences, is whether or not they have a positive adult role model in their life. That's on one side. Then we have all these disconnected aging folks out there and or folks with disabilities who are sitting at home alone and getting depressed and having suicidal thoughts because they're isolated. So why can't we connect these folks together and again look at these aging and disabled folks as a strength, an untapped strength, instead of, oh my gosh, it's someone that we got to take care of. The workforce, again, a strength. If we can get a 72-year-old to come back in and work even 10 hours a week, that's a strength for our economy. Instead of saying, oh my gosh, we got to figure out how we're going to pay for their Social Security and their Medicare, why don't we say, okay, how do we enable them to come back and be part of this society so that we can be economically competitive and vibrant, and then we have more than enough money to offset those costs. So I think that strengths perspective is incredibly important, and not just talking about the problems and the deficits.
I need maybe some input from you as to how do we get certain data, because I'm on the newly formed Westfield Mayor's Council on Disability, and there are a lot of people in the community that want to volunteer. You go to Facebook and there's tons of volunteer groups, and we're trying to figure out how to create community programs, social activities, transportation, help, all kinds of help through volunteer, because there are lots of semi-retired and retired people out there with time on their hands, and they do want to do that. But my thing is that I need some data. I've contacted the 6 case management companies, and I've asked them to see if we can get them graphics. A couple of them have sent me just the state statistics. Like, I want to know, and I'm just only talking about Westfield, but what percentage of the people who live there, how many have a disability, what type of disability, what is their living situation? Are they in group home supported living or at home? And then are they working? Just maybe 4 or 5 basic You know, so you can then go out and be better equipped to form volunteer groups to have social activities. And then the other thing with volunteers is that a lot of people with disabilities go through home rehab to get a job. Well, you've got 90 days for your job coach, and then some people need longer onboarding. If there's a way to vet volunteers so that they could walk into a company, like we as volunteers can't do that. I know Shepherd Center in Noblesville has a vetting process where they vet their drivers, like if you're going to offer, you know, transportation. Like we as a group of volunteers can't just throw people's phone numbers out there and tell you to have your brother get picked up by some person that's not vetted. So those things that we're trying to figure out, but I think if we can get volunteers who are happy to go into this industrial company to hang out with this person for 2 hours a couple times a week and serve as an unpaid job coach, the companies are so bare bone that they don't have time to hold their hand. Like my brother, like your brother, he moved in with me after being in supported living. He's working at Culver's. He's still having a really hard time opening up the ketchup, the bag, because it's kind of soft and mushy. I probably would get fired. Try to, fill the condiment. So, but he still has a job coach. But if he didn't have a job coach, they're so spread thin at Culver's. I mean, their managers are doing 12 jobs.
Yep.
So I'm just throwing out this idea of how do we get these volunteers organized. And secondly, I need to know from you specifically, how do I get this data? Because I contacted FSSA, I heard back from BQIS, and there's this big convoluted form, like it's called ARPA or APRA or something. We're not at that point. Like I just want simple numbers. So those are my 2 questions.
Dr. Kane, do you have any insight on that?
So just listening to her. So what happens is with some of the local health departments, a number of us, we only do it about maybe every 4 or 5 years where we try to do a community health needs assessment. And what happens with the community health needs assessment, we'll hear from some of our partners or organizations to say, wow, I really want to know this answer. Is there any kind of way you can add this, can you add these questions in so that, you can do a survey and get that answer from you. Now, I'm just trying to think about this because, I'm in a better position in Marion County because I have a whole team of what we call epidemiologists here, the data gathering folks, and I go for grants, and so neighborhoods can come and say, organizations can come and say, I would like to know this answer. Could you assist us in doing this survey? I hope prepare this survey and help get this information. So you may have that ability. Westfield is Hamilton County, right? So you may have that ability where you can ask the health department from Hamilton County, could they help assist you just for this small little survey? And sometimes the small health departments have to ask the state Department of Health to help with their epidemiologists in regard to this. And so see what kind of results you get. Now, I'm terrible, so that if you're not successful, we might be able to help you out in Marion County for Westfield.
Thank you,
Yep.
Dr. Kane.
And so we've got to close, but thank you, Dr. Kane. And I want to second that. First, they have to have the data. And as Dr. Kane said, not everyone's collecting the data and they're not collecting it regularly. And that goes back to what Representative Porter said. They're looking at trying to allocate several $100 million to go towards public health. And one of the things we talked about at the Public Health Commission meetings was the need for better data collection. So all of you all need to say to your legislators, we can't find the data that we need to be able to unleash the power in our own communities to help lift up our health. We need more money committed to data collection so that you can have epidemiologists at every health department who can collect this data. Also, again, schools. Going again to Butler or IUPUI and reaching out and saying, hey, is there a grad student or someone who wants to take this on as a project.
Well, the key, so what department would I contact? The Department of what?
Dr. Kane can put you in touch with Paul Halverson, who's at the IU Fairbanks School of Public Health. He would be a good person to start with.
Public health.
So they can, so I would go to them first because they have all these students, and for them to get a master's, their master's, they have to have a project to do. And they will provide the technical background and assistance to do it. And so that's Dean Paul Halverson. I'll be able to get you his phone number before we leave today.
And we have to wrap up. It's my birthday. And
Yes, it is your birthday, so here we go.
Yep.
And I know you want to say something about that right before you do.
Oh.
Happy birthday to you. Happy birthday to you. Happy birthday, Dr. Adams. Happy birthday to you. Yes.
Well, thank you. Thank you so much. I do. So I am on the Rehabilitation Hospital of Indiana Foundation Board, and RHI helps take care of people after they've had a stroke or a spinal cord injury or a number of COVID. They help take care of them and get them to the point where then they can hopefully transition back into the community, and then CICOA can support them. Today is RHI's annual day of giving, so if you all want to give me a birthday gift, then you can follow that QR code, go to that website, you can give $1. You can give whatever you'd want to give. That's going to help support the very people who we're here today to lift up. So thank you all again so much for what you do each and every day. Thank you for your attention and your engagement in this conversation. And know that we've got a lot of work to do, but I'm heartened by the fact that you all are here, and there are many people out there who are committed to doing the work. We are moving in the right direction. Representative Porter is going to get us at least $200 million, if not more than that, to go towards the Public Health Commission. You've got schools who are interested, and Purdue is throwing their weight behind it with millions that they put toward the health equity cluster hire and support of Checky and what I'm doing there. So be heartened. A lot of work to do. But I do feel that there's many positive signs that again, we're moving in the right direction to provide a more equitable environment and equitable communities for people with disabilities and people who are aging. And thank you, Dr. Gonzalvo. You were fabulous.
Hey, let's give a round of applause. Awesome. So just to finish up, it was awesome. I know one of the things that really stood out to me is something that's kind of our philosophy here too, a business model supported by data. Mm-hmm. That's how we're going to make a difference. So Tarek, we've got a lot of questions from our live audience today, but there's some questions from our streaming audience. So if you want to, I'm going to hand the mic back to you. You can read these to Dr. Adams and Dr. Gonzalvo. Okay. And then that way we can answer, see with what time we have left, we'll try to get these answers.
Very good. Thank you, Steve. So, I don't really need a mic. My voice is deep enough and loud enough. So, Dr. Adams, you spoke briefly about the difference between sick care and health care. Are there any current policy initiatives, state or federal, being made to move the needle from the fee-for-service model to a more value-based care model?
So absolutely, that's an easy one. I was at an ACO and Payers conference just last Friday. Anthem, Blue Cross, Blue Shield, Aetna, they're all looking at how they move from that fee-for-service world to that value-based purchasing world. And I think the advantage for community health workers, for people who are trying to age in place, is that when you shift from fee-for-service, where they get paid every time the patient comes in the hospital, to value-based where you pay to keep them out of the hospital, that unleashes the ability to be able to pay for a community health worker on the hospital's part, because now they have an incentive to say, okay, we're going to get paid more, or at least we won't get penalized if we keep you out of the hospital. And if a community health worker helps us do that, if giving someone an extra $50, a day to be a caregiver and care for you at home does that, then there's going to be a model to help set it up.
Very good. So this next one is coming from a healthcare provider working closely with a group of faith community nurses and wants us to know that FCNs are unpaid caregivers. So the question is, who can I contact to partner with a student who needs data for a program he or she is interested in?
You have thoughts about that, Jasmine?
My center. So the Purdue Center for Health Equity and Innovation, we have a whole team of people who really focus on health access for different communities, for diverse communities who historically have been marginalized or suffer from health disparities. So that's one of them, is me.
Yep, and then the Fairbanks School of Public Health. Like I said, you can reach out and see if they have folks there who need a project. And big shout out to our faith communities out there who really are the de facto care home for individuals who have been marginalized and under-resourced, for our aging and for our disabled out there. We need to do more to understand them and to support them.
Very good. And then this last one appears to be more of a comment, not necessarily a question. It just says we need to continue to put the word out there about adult day services and how they will help all care partners. And in doing so, we need to keep in mind, even when the person graduated to the next level of care, that care partner is providing that care after that point and beyond. So that was all the questions that we have. Again, thank you all for your time spent with us today. Dr. Adams, Dr. Gonzalvo, thank you again for sharing the stage with us today. And you guys have a great rest of the afternoon.
Thank you, everyone.